there was a really big response to the Mercola rebuttal. So I want to thank you all for your responses to the Mercola rebuttal. And of course, the Dutch podcast was launched 2 days later and entitled The Dark Side of Estrogen. And that created a huge response. They got so many letters from so many practitioners that were upset and women that were upset. So estrogen and hormones are definitely in the news. And I want to thank you for all your support. What we're going into today is in response to a growing movement, even in A4M, to tell doctors not to prescribe testosterone to women. What is the reality with that? So when I was in Chicago 3 weeks ago at A4M, which was a newbie hormone conference, there were 700 doctors there, nurse practitioners, a variety of provider licensures. Pam, who I really appreciate, but we have differences of opinion, Pam Smith in her lecture said that testosterone was a narcotic. You should never prescribe testosterone to menopausal women because it causes plaque. There's a very tiny amount of women that benefit from it. You should basically not think of it as part of your bioidentical hormone replacement protocol. This is not how many people in the field feel, so I decided to do a deep dive in the literature and see what she was talking about. I asked her, where are your articles to substantiate what you're saying? And she said, go look in my book, go look in my book. So I didn't feel like going through the whole book, so I decided to just dive into the literature myself and then share this with you because this is a very big deal. A4M is basically telling new providers, when you learn hormones, don't test or treat with testosterone. How true is that? How much would your ladies be missing out? What is the reality? So I decided to put this talk together, and I would love your feedback on it. And then we also got some questions from providers that were saying, well, what if men want to preserve their fertility, but they're young and they don't have testosterone? We've mentioned this before, but I added a lot of those slides in here too, so that when you get these slides, it covers what testosterone does, the safety of testosterone in women, 1 or 2 of the articles that suggest it's not safe, but there's many more that suggest it is. And then also I have articles down at the bottom about how to use human chorionic gonadotrophin to preserve testicular functionality if you do want to give hormones to younger males, or they've been given it already and lost their fertility. How do you reboot their fertility? So that is the set of slides that we're going to go through at the moment. Are there any questions before I start? I don't think so. So we're going to share my screen. Okay, and view slideshow. Take my picture down here. So we're talking about testosterone efficacy, safety as replacement in perimenopausal and postmenopausal women, and some stuff about guys at the end. So, okay, going to the next slide. So first of all, the biggest thing that I see testosterone replacement helping women as they age is it helps maintain your muscle mass and it fights sarcopenia. Muscle mass, the more muscle that you have, that's why I wore a sleeveless top this morning. This is a lot of muscle here. And muscle, when it's recruited, protects your eyes and your brains, and it slows down aging. If you have less and less muscle, you have more mitochondrial dysfunction because there is a give and take between your mitochondrial piggy bank and reserve and how much muscle mass you have. And as you have less muscle, you have more cellular aging and poorer autophagic processes. So maintaining muscle mass is a big deal, and it's really hard to do. One of the first things women come in their 40s and 50s is say, I'm working out as hard as I used to work out, but I'm not maintaining muscle mass and I feel like I'm even losing it. And remember, muscle mass also helps you keep extra weight off. And even in a small frame, a few pounds can make the difference between heaven and hell, for sure. But we've all thought that basically, I guess these are a little bit, sorry, these aren't as crisp as I would like, that losing muscle mass is inevitable. So this is one of muscle mass is, and testosterone is made when we work out. When you have resistant exercise in men and women both, you make more testosterone. Your heart is a muscle. Muscles give off myokines that protect eyes and brain. Testosterone is all about muscle, but is testosterone safe? And one of the things you're going to learn is testosterone is safe, but it also needs to be given to a woman along with estrogen. It's not something to be given without estrogen. It's the ratio between testosterone and estrogen in replacement. So that's a pretty new concept, and we'll be seeing slides on this in a minute. One of my favorite studies that came out in 2011. It came out in Physician Sports Medicine. And the name of the study was Chronic Exercise Preserves Lean Muscle Mass in Masters Athletes. And they define Masters athletes as people who worked out an hour a day for at least 6 days a week. And what they did was they say, you know, this study, they did MRIs of the quads of master athletes in their 40s versus master athletes in their 80s. These people were not on testosterone replacement. They were using exercise to maintain their muscle mass, but they were called master athletes, and that was equivalent to an hour of a robust, moderate to vigorous workout a day. They discovered that people in their 80s, here is a 70-year-old triathlete. Sorry, it was in their 70s. Here's a 40-year-old. This is all muscle mass in the quad. This is the bone in the middle. This is a 74-year-old sedentary man where the muscle gets replaced with fat, and fat drives frailty. There's no way about it. The more adiposity that you have on your body, the more it drives frailty. The more muscle mass you have on your body, the less. So they said this study contradicts the common observation that muscle mass and strength decline as a function of aging. Most doctors will say to patients, especially starting in their 40s, you know, you're not getting any younger. Most people expect frailty. That's one of the things that testosterone replacement can do, is slow down those non-accurate perceptions that you need to become more frail as you age. They said these declines may signal the effect of chronic disuse. We tend to move less and demand less of our muscles as we age rather than muscle aging. So this study was an evaluation of master athletes in how much muscle mass can they maintain at 70 to 80 years old versus somebody in their 40s just based on exercise. This is the average loss of muscle mass starts exactly when you start losing your hormones. Your highest hormone mass in your life is at 25. You start going downhill from there, and so do your muscles start going down there from there. And as muscle mass loss accelerates, frailty accelerates. The two things that offset that are very consistent, disciplined exercise or testosterone or androgenic replacement. The summation of this article in Physician Sports Medicine was that aging or frailty of muscles is not inevitable. We don't need to decline and age in the way that we thought that we did. And there's two aspects: exercise, which also makes testosterone, and testosterone replacement. So exercise increases testosterone, lovemaking increases testosterone, a healthy biome makes androgens and testosterone. You can also be on hormone replacement and bioidentical hormone replacement, but testosterone is under attack by endocrine disruptors, just like estrogen is. Most people think of endocrine disruption as mostly estrogen disruption, but our toxic planet is assaulting many of our hormones, and most of this assault sets up epigenetically prenatally. And we are now seeing young males coming in with testosterone at the level we used to see in 60 and 70-year-olds. And we're seeing in women lower estrogen, and in some women higher testosterone and PCOS, and in some women insufficient testosterone. So it's kind of all over the map in women. Testosterone, we know, is also very breast protective. Testosterone metabolite goes from testosterone to DHT to 3-beta-diol, and 3-beta-diol looks almost exactly like soy. And it signals the second estrogen receptor, which Yanaki Gustafsson, who discovered it, has been pumping out articles in the last few months that the second estrogen receptor acts a lot like a tumor suppressor or chemotherapeutic agent. It's an anti-cancer agent. And testosterone's final metabolite, 3-beta-diol, signals this natural chemotherapeutic agent. So as we age, we're more at risk of cancers. With testosterone replacement, it makes sense that we might be less at risk and being more cancer protective. We know from the exhaustive work of Rebecca Glasser that women who have lower testosterone are more prone to getting breast cancer, and also especially lower testosterone with higher estrone, because estrone is the one estrogen that promotes more growth signals than not. We also know that testosterone protects heart cells, and it's one of the reasons that we're seeing more women be protected when they're on testosterone replacement against stroke and heart attack. And testosterone also protects the hippocampus. There's studies out of China that the higher level of normal testosterone you have, even if you have the ApoE4 gene, the gene doesn't express. So testosterone protects the brain against Alzheimer's by tamping down the Alzheimer vulnerability gene, the ApoE4 gene. Testosterone protects growth out of control at the breast, and this is exhaustive work by Rebecca Glasser and her colleague, Dimitrakakis. We know that testosterone protects against autoimmune diseases. So if you have any patients with MS, with rheumatoid arthritis, with mixed mucosal connective disease, Wernicke's granulomatosis, type 1 diabetes, all of those patients seem to improve with some testosterone replacement, because testosterone protects the gut, and the gut is one of the main sources of dysfunction that makes you more prone to an autoimmune disease. Out of the 159 autoimmune diseases, women have more of all of them because women have less testosterone. It's also the same with dementia. Women get a lot more dementia because testosterone is so brain protective. Women get a lot more autoimmune diseases because testosterone is so autoimmune protective. This is some of the studies. There have been quite a number of them now, and they've inaugurated larger clinical trials that are in process right now of giving estriol and testosterone, which, by the way, both signal that second protective estrogen receptor. And estriol and testosterone are remyelinating hormones. They're anti-inflammatory, remyelinating. So there's something you want on board as you age, because you'd like to protect the myelin sheath of your hormones. Both testosterone and estriol have been found to induce anti-inflammatory as well as neuroprotective effects. Findings from two recent, and this was published in 2009, recent pilot studies of giving testosterone in males and oral estriol in females are encouraging, because the white matter lesions in these MS patients really shrunk, and they had improvement in quality of life on a number of indices. So testosterone is very autoimmune protective. One of the things I have all my older patients do when they go in for a colonoscopy is ask their doctors to do small little biopsies of the colon, because the only way you can diagnose microscopic colitis when you get older is through biopsies. It's not something that can be visualized. And this is an autoimmune process in the gut that happens more and more as we age, because we have less and less testosterone. And if it comes back that my patient has microscopic colitis, which is an autoimmune issue in the lining of the gut that happens more and more as we age because we have less and less testosterone, I usually make sure that I have testosterone replacement on board, as well as other gut protective actions. Increasing evidence on greater risk of multiple sclerosis associated with lower testosterone levels is being reported. Epidemiologic studies have shown a later age of onset of MS in men because that's when they have less testosterone. And so if you have autoimmune patients, you want to not leave testosterone out of a possible addition of your bioidentical hormone mix at any age. And we're going to talk about age and hormone replacement in my Sunday Substack, by the way, because everyone's saying, well, if you have an 80-year-old woman or a 90-year-old woman, can you initiate hormones? That's going to be Sunday's Substack. They did find, and this is an analysis of 96 men with an average age of 40 years. And of these men who all had MS, 40% had a total testosterone under close to 300 nanograms per deciliter. But most men don't feel better until their total testosterone goes above about 650. That's where most men start feeling really well. And my male patients in Naples that are in their 90s and really robust, their total testosterone on their own is usually 700, 800, or 900 nanograms per deciliter. So to be truly hypogonadal, your testosterone levels need to be very low. And so they were basically looking at how bad is your MS compared to where your testosterone levels are. This is a study in males. A lot of the testosterone studies are in males, but I've pulled a lot of the literature out in females, and we're going to be going through that in just a few minutes. The conclusion of this study was men with MS may experience insufficient testosterone, which is associated with worse clinical outcomes. So, and this study came out of Harvard, by the way. So there's a potential neuroprotective role for testosterone that warrants investigation. And so I look at testosterone replacement and most of my autoimmune patients, regardless of their gender. This was in males, but I do it in both genders. What's the big thought in functional world is autoimmune disease comes when you have a leaky gut, and then you have bacterial translocation of things within the gut that shouldn't get into the bloodstream because the gut is more wide open rather than closing and opening like it ideally should. One of the things that can translocate across the entire enterocyte lining is LPS. We know this is one of the most, lipopolysaccharide. It is a moiety that should stay in the gut, shouldn't get into the bloodstream. And when it crosses into the bloodstream, it puts the immune system on overdrive. So it's one of the accelerators or drivers of the autoimmune underlying mechanism. In this study, it showed that the second metabolite of testosterone goes from testosterone to DHT to 3-beta-diol. The second metabolite of DHT reduces the leakage of LPS across the gut wall. And in this way, and other pro-inflammatory molecules. And in this way, testosterone is a caretaker of the open and closing of the gut, which is why it's such a great thing to add on to prevent autoimmune diseases or to be part of your tool bag for patients with autoimmune disease. So we show that DHT inhibits LPS-induced release and many other pro-inflammatory markers like TNF-alpha, interleukin-6, which is one of the most pro-inflammatory interleukins. Testosterone reduces all these inflammatory molecules. There's a consistent presentation in the literature that estrogen and testosterone reduce pro-inflammatory molecules. And testosterone in particular reduces also pro-autoimmune inflammatory molecules. And we don't think of testosterone in that way. This study suggests that T, the second metabolite of testosterone, exerts anti-neuroinflammatory and has neuroprotective effects. Thus, androgen replacement therapy is potential therapeutic strategy for improving cognitive and behavioral function in neuroinflammation-related diseases. And most women, when you start replacement with a little bit of addition testosterone, have a better, cheerier, rosy look out on the world, and the same with men. There's a French study that showed also that it's a phase 2 multi-centered randomized placebo-controlled double-blind study which aims to prevent the progression of MS in men with low testosterone by giving them testosterone. And now again, this is in men, and we're going to get to women soon, but what they basically showed was that testosterone was a remyelinating and a neuroprotective hormone. So is this just going to be in patients with MS? No, it means that it's going to protect our myelin sheaths and our nerves in all of us. But this was a very interesting study. But in MS patients, if you're not really looking at the addition of hormone replacement, then the patients miss out. So testosterone protects the brain, especially the hippocampus. It tamps down the ApoE4 vulnerability gene. It protects bone. It promotes healthier insulin sensitivity, as low testosterone is highly linked to insulin resistance. It boosts gut wall immunity as it boosts secretory IgA. And testosterone levels are inversely related to arterial stiffness. The more testosterone, the healthier the heart and blood vessels. And there's 2 studies that support this. So what Pam said is testosterone causes plaque. So I started just diving into testosterone and found many more studies that show that healthier levels of testosterone give you healthier blood vessels than the opposite. But there's 2 studies that suggest it does cause plaque, and I'm going to kind of pull those studies apart and say that they don't hold up to the body that's saying that testosterone is actually cardioprotective. This came from the academic unit of diabetes. This is a British group of researchers. It was also published in Atherosclerosis, the effects of testosterone on risk factors for and mediators of the atherosclerotic process. And the biggest thing that Pam said is testosterone causes plaque. That's what she said. And people were coming out of that talk going, what? This article that came out of the academic unit of diabetes, endocrinology, metabolism from Britain is becoming increasingly evident that low levels of testosterone experienced by aging men are associated with increased all-cause mortality from coronary heart disease. And they wanted to take a deep dive on understanding the effects of testosterone on cardiovascular risk factors. So a lot of the original study of looking at testosterone and what it does to blood vessels came from men. I'm going to soon be going to some of the one with women. The FDA mandated, is testosterone replacement healthy for heart tissue or not? You've got to do a study on this. It was the Traverse study. It was initiated in 2015, and the results were published a few months ago. And they basically said that testosterone is good for the heart. Good for the heart. They looked at 5,000 men aged 45 to 80. They were randomized to daily transdermal gels or matching placebo for an average of 22 months. And according to this is the largest study ever run. Testosterone therapy is fine, even for most older men who all have some level of heart disease. Low levels of testosterone are associated with an increased risk of death from all cause, and low levels are inversely related to heart disease and even cancer deaths. So most of this is in males, but we're going to be going soon into females. But why would it do such a different action in one gender versus the other? Higher levels of T, if they go too high, are linked to lower heart attack occurrence. Higher levels of normal levels of testosterone are linked to having less heart attacks. Healthier levels of HDL are linked to healthier levels of testosterone. This article basically said testosterone exerts an anti-atherogenic effect. This data suggests that testosterone intensifies reverse cholesterol transport, exerting an anti-atherogenic effect rather than a pro atherogenic effect. This is one of my very favorite studies. This was done by a compounding pharmacist from Texas. And when she first tried to publish this study, they threatened to have her lose her job, and they eventually did fire her from where she was working at one of the universities in the Texas university system. They did not want this information coming out on bioidentical hormones, so she had to go out of the country and get this article published in the International Journal of Pharmacology and Compounders. And it's the most intensive study on human women done on giving them hormones. And I'm going to share how they also added in testosterone, and then looking at all cardiac parameters in detail, from arterial stiffness to different pro-inflammatory compounds. This is the most intensive study ever run. She had to go out of the country to get it published. They finally kicked her out of the system. So this is an amazing study. And they looked at 75 women, and they examined all of their hormones. They looked at their stress levels. They did in-depth cardiovascular examinations, kind of like a Cooper clinic on these women. And they ended up testing them on their hormones and putting everybody on individual amount of Biest, which was 80-20, and or progesterone for 8 weeks to meet established physiologic reference ranges. And then they retested them at the luteal range. And if any of them after 8 weeks were low in testosterone, they added in androgens of DHEA and testosterone. If women and they looked incredibly at all of the different things that impact what testosterone might do on the cardiovascular system. They looked at blood pressure. They looked at insulin resistance, fasting triglycerides. They looked at multiple factors that would make you more at risk for stroke or not. These are all your coagulation factors like fibrinogen, plasminogen. They looked at your C-reactive protein, interleukin-6, your matrix metalloproteinase gives you a really big look-see into the health of the blood vessels. They looked at all of these different things along with their stress levels and their hormone levels. Half the women were on hormones, half the women were not. And they went in once a year for 3 years to get all of these parameters measured. And the conclusion was administration of compounded transdermal bioidentical hormone in doses targeted to physiologic reference ranges. So all women were individually tested, and hormones were recommended based on their test results, although they tried to keep the Biest in an 80-20 ratio. And they followed them for 3 years. Cardiovascular biomarkers. So these women were on estrogen, Biest, progesterone, and if they needed it, on testosterone. This is the best study we have taking a look at the effects of testosterone on women. Thank you, Kenneth Stephenson, and sorry that you were so mistreated in Texas because you were willing to do such great work. I'm just trying to remove this. So cardiovascular biomarkers, inflammatory factors, immune signaling factors, and health outcomes were favorably impacted despite very high life stress and home and work strain in study subjects. Most people living in the United States today, and this was even pre-pandemic, state that they have a very stressful lifestyle. My girlfriend that's visiting right now, she's been traveling all over the world. Her and her husband retired, and they've had this dream of traveling all over the world, and they're doing it. And they meet all these expats from America because people were tired of being so stressed out. These women on hormones, besides having no adverse effect on their blood vessels, consistently said, hormones helped reduce my experience of my level of stress. Hormones foundationally, if they're replaced individually, make us stronger. None of the cardiovascular markers, which were looked at in detail, and this is really a human female trial, were worse. This therapy did not adversely alter the net prothrombotic potential. So to say that testosterone causes plaque, here's a very in-depth human trial where they looked at so many indices of cardiovascular health, and they could not find, there were no associated adverse events. This model of care warrants consideration and is effective and safe clinical therapy for peri and postmenopausal women, especially in populations with high perceived stress and a history of stressful life events prior to or during the menopausal transition. This is really one of the most amazing studies that we have. There's never been a study that looked at all the cardiovascular parameters so clearly, and there was no adverse cardiovascular issues, and women just felt so much better on hormone replacement. And you all know what's going on. There's a cultural movement to make women more and more fearful of hormones. And I think that's so that they'll use many other drugs. If you're not on hormones to protect your bones, then you're going to be on a pharmaceutical agent to protect your bones. And I think it really comes down what's going on with our country. And Dorothy and I were talking about this morning, is we're just being ruined by greed. It all comes down really to greed. And everyone wants to make more money, and profits are more important than protection of humanity on every level. So we can't miss out from other people's greed. And that's really important to kind of tease apart the truth. This one study, let me get out of here. Testosterone levels not linked to plaque in either sex. So this came out, it's called Associations of Endogenous Estradiol and Testosterone Levels with Plaque Composition and Risk of Stroke in Subjects with Carotid Atherosclerosis. So, you know, after you get 55, every 5 years, you want to do a calcium score study, which is a 30-second fast CT scan of your coronary artery to see if there's calcium in there, because calcium in arteries is a suggestion of plaque. You also want to get your carotids ultrasounded to make sure there isn't a thickening of the lining of the blood vessel or plaque. And that's something that we should all do every 5 years, at least once we get over 55. And a calcium score of over 100 means plaque is starting to be laid down, and you need to do something to reverse it. And calcium scores of over 475 mean you're a high risk of a heart attack. So calcium scores give us some idea of your risk of heart attack and what is going on with plaque deposition in your arteries. Usually that test is about $100, and usually the carotid ultrasounds are about 50 to 75. So these are things we all should be doing, and also making sure that our patients are getting. So that's what this study was about. They took a look at people, patients, they ultrasounded their carotids, and they looked at 1,023 postmenopausal women, and they also looked at gents, 1,124 gents, all of who, when they had ultrasounds of their neck, showed some atherosclerosis. And then they took a look at their level of hormones and linked their hormones to how much plaque that they had. So this was in both genders. And it was saying, well, if people have plaque, what's going on with their testosterone? Is there an association that A4M is teaching or not? And they measured total estradiol, total testosterone, and carotid atherosclerosis was assessed by ultrasound, whereas plaque composition was assessed by magnetic resonance imaging. And they found that estrogen and testosterone were not associated in any way with calcified carotid plaques in either sex. I spent a day just scouring the literature looking for all of this. This is a rodent study where they examined the effects. They over-rectomized female rodents, and which starts to accelerate plaque development. You remove the ovaries, you start getting a lot more plaque. And then they gave testosterone to female mice to evaluate whether adding low estradiol or testosterone would reduce those plaque lesions or not. Now, this is an in vivo study. It's in rodents, but this is a pretty interesting study. So they took a look at 6-week-old female mice who got their ovaries removed, and then they began to give them testosterone, estradiol, testosterone with low dose estradiol, or placebo vehicle alone, and they monitored their lesions. This is a very cool study. We found reduced atherosclerosis in the mice who had been treated with estradiol along with testosterone compared to those treated with either testosterone alone or estrogen alone. Testosterone estradiol combined therapy resulted in less atherosclerosis plaque formation than either other interventions after the ovaries had been removed. So we're starting to kind of see a theme. We don't see that testosterone worsens. We see that it helps reduce stress, and it reduces even plaque size. And this came out from the American College of Cardiology, and it's called Hormone Replacement Therapy Associated with Lower Mortality. And the title, this was presented at a poster session at the American College of Cardiology in 2017. And poster sessions, when you have a big conference, often PhD and postdoc students that are doing a lot of research, but they're not speakers on the podium, but they have a poster, and you go in and you talk to them about all of their research, and you get updated on the research that's happening around the country. So this was a poster session presentation at the American College of Cardiology, and it was called Hormone Replacement Therapy is Associated with Less Coronary Atherosclerosis and Lower Mortality. It's not going to make you immortal, but it makes you live longer. And that is really a consistent theme in the science. Women on hormone replacement tend to live anywhere from 20 to 30% longer. We live longer with a higher quality of life. The 7 million study out of the NIH said 20% longer, and one of the other studies said 30%. But look at this, women using hormone replacement therapy. I just copied what these, I forget where this came from. I don't know who was presenting this poster session, but women using hormone replacement therapy were overall 30% less likely to die than those not on hormone therapy. Not that they're not going to die, but that they live an average of 30% longer. This was a retrospective analysis of the health records of more than 4,200 women who received a calcium score at Cedars-Sinai between 1998 and 2012. And of course, the calcium score is what's going on with calcium in your coronary artery, because it's a marker for a buildup of plaque. 41% of the women reported taking hormone replacement at the time. So they were looking at the difference of the calcium plaque of women on hormones and the women not on hormones. And then they looked at how long they lived. So women on hormone replacement had less plaque and lived longer. This is so replicated in the science that it's hard to believe we're making women so frightened of hormones. Women using hormone replacement therapy were also 20% more likely to have a coronary calcium score of 0. Oh my gosh, calcium score of 0 means you have really 0 likelihood of a stroke or heart attack, the lowest possible score, indicating a low likelihood of heart attack. This is exactly their words. I didn't change them. And 30% less likely to have a coronary calcium score above 399, which is indicative of severe atherosclerosis and a high heart attack risk. And these are women who were on estrogen and progesterone. The NIH this is the largest study, and I've gone over the study with you several times now. It's still in peer review, but they looked at 7 million women that were 65 and older, and they said, how many of these women are on estrogen? And 1.5 million women were on estrogen. So they went back and went into the records, because they were all on Medicare, so their records were all available for the government to take a look at. And they looked at their survival, their cancer, their cardiovascular and dementia risks in 1.5 million women on estrogen. And they found that the women who high-risk cardiac patients, that means these are patients with some congestive heart failure, some heart disease, some plaque, a calcium score that's really starting to elevate. These women on hormones had the best longevity outcomes, not worse, as is standard of care. So standard of care says if you've got heart disease, and you're older, you're not a candidate for hormone replacement. This is crazy. In this study, that's now the largest study ever done on hormones, and they went directly into their records, and it was a retrospective study, so they looked at their health. This is 1.5 million women. They're looking at this. Menopausal hormone therapy is indicated for relief. However, menopausal hormone therapy has also been shown to be beneficial for prevention of long-term estrogen deficiency, including mortality. Based on a comprehensive literature review, they did a meta-analysis of 31 observational studies that all support this data, that in postmenopausal women, menopausal hormone treatment, that's what MHT stands for, appears to confer a significant reduction in overall mortality. The benefit especially applies to women who initiate long-term menopausal therapy early after menopause, but it still can be initiated at any age in women with prevalent cardiovascular risk factors, except for diabetics, where the results were mixed. So women who had elevated lipids, elevated plaque, a history of a stent, diagnosed with COPD, older, sicker ladies, the benefit of menopausal hormone therapy on overall mortality is even more pronounced and better. But they said the results are a little bit difficult to compare because it was not that easy to assess this. But that means, including this study, there's 32 studies that suggest that older women with heart disease fare better on hormone replacement. So it's not worsening their heart disease at all, it's improving it. But of course, the best outcome on heart disease is if you start hormone replacement later in the perimenopause and early in menopause, but you still get benefit even when you're older. And standard of care now says if you haven't initiated hormone replacement therapy in your 50s and you're 65, you've missed your window. You've missed the estrogen window and you're at risk. And that's not what the science says. This study came out of a very interesting group. It was the Division of Cardiovascular Medicine at Gill Heart Institute, the University of Kentucky, the Division of Cardiovascular Medicine at Texas Tech, which is where Kenneth Stephenson had worked. This is all really intense Texas prestigious institutions. And the name of the study is Women, the Menopause, Hormone Replacement Therapy, and Heart Disease. And they said early menopause at age 39 years older and late menopause at age 56 or older increase the risk of cardiovascular disease. So HRT should not be prescribed as a prevention of heart disease, but when less than 10 years from menopause at a normal age, now this is the estrogen window that I don't agree with, but women can be reassured that cardiovascular risk from hormone replacement therapy is very low. And the name of the study is Women, the Menopause, Hormone Replacement Therapy, and Coronary Heart Disease. And they looked at women on estrogen, progesterone, and testosterone. They are saying there is an estrogen window, which I don't agree with, but they basically said hormones don't worsen heart disease. They actually improve it. One of the big genetic factors of your risk of stroke is your lipoprotein little a. Lipoprotein little a is something that everyone should run, and it tells you if you have a higher risk of stroke genetically. Ashkenazi Jewish people have very elevated lipoprotein little a. Dr. Brownstein and I were talking to each other. We're both Ashkenazi Jewish backgrounds, and we both have very elevated lipoprotein little a. And estrogen lowers it in women, and testosterone lowers it in men, and it's a major pro-cardiovascular inflammatory marker. This looked at almost 3,000 postmenopausal women younger than 80 years old, all with coronary artery disease, and they also had a uterus, and they randomly assigned to either receive Premarin, it was really a synthetic progestin, or placebo. And so, of course, they were using the same hormones that were used in the original Women's Health Initiative. So they were using oral Premarin, conjugated equine estrogen, or a synthetic progestin, and treatment with estrogen and a progestin reduced the levels of lipoprotein little a. Our data suggests that lipoprotein little a is an independent risk factor for recurrent coronary heart disease, and treatment with estrogen and progesterone, although we would use different forms of this, lowers lipoprotein little a. Estrogen and progestin therapy appear to have a more favorable effect in women with higher initial lipoprotein little a's than in women who don't. They didn't look at testosterone, but I wanted to show you this. Oops, I'm missing an A over there. It just giving estrogen, and of course this was oral Premarin, decreased almost 40%. Let's see, and this is when testosterone decreases lipoprotein little a in men. The average lipoprotein little a when they gave testosterone replacement to men almost went down by 40%, And that's pretty amazing. So there's more studies on this, that hormones make your risk factor for heart disease behave better. We know that estrogen, of course, promotes healthier blood vessels. That's why, the number one cause of death is heart disease. And estrogen and testosterone actually protect against heart disease. In this one study, this was an earlier study, but from the American Journal of Cardiology, we conclude that estrogen replacement may offer protection against clinical coronary events in postmenopausal women who already have established coronary artery disease and are undergoing balloon angioplasty, and the benefit was independent of a lot of other confounding variables. We die more of heart disease. Hormones protect against heart disease. I hate to have us start to think that hormones promote heart disease. Here's another study on androgens and coronary vascular disease, came out in Endocrinologic Reviews. They took a look at a large amount of data that was out there on exposure to male hormones and onset of heart disease. Observational studies show that blood testosterone concentrations are consistently lower in men with cardiovascular disease. Short-term interventional studies show that testosterone produces a modest but consistent improvement. Again, this is in men, but why would it be so different in women? In cardiac ischemia over placebo, comparable to the effects of existing anti-angina drugs. So hormones do so many things, and hormone replacement therapy will not make you immortal, but it often allows you to be exposed to less pharmaceutical intervention. And that's one of the biggest boons of hormone replacement. So I hate to make women frightened of testosterone. This came out, androgens and cardiovascular disease, again in both genders. Concerning women, both high and low levels of endogenous androgens have been associated with cardiovascular disease, while other studies show no association. And not regarding testosterone therapy in women, there have been no large prospective studies on cardiovascular outcomes. Concerning men, most studies indicate that low levels of circulating testosterone make all cardiovascular disease worse. Testosterone replacement does not appear to testosterone replacement used to treat low T doesn't appear to increase the risk for heart problems, as some experts had feared, according to research published in the New England Journal of Medicine and presented in Chicago a few months ago at an endocrinology meeting. So it's all changing, but it's not been translated into how patients sitting in front of you are treated with hormones and how providers are taught about hormones, it seems, in some of the other institutions. Let's see, there's a chat here. Is there a question? Linda says, if there is a clear science that says HRT is beneficial, why does Dr. Smith speak about the detriment? How to counter the spread of misinformation or disinformation? I know you've been asking the same question, but it's tricky without having the supposed credibility of an MD. You know, I don't really have that much respect anymore for a lot of medical doctors' understanding of hormones now that I've been in that space for so long. But that's a really great question. I'm going to show you just a few of the studies as we go a little further along, linking, and I know that Sarah's got to leave in just a little bit of time too. But she says that testosterone causes plaque in women. I've asked her for those citations. She didn't give them to me. And I went through all the citations I could find in this talk that we're giving today. So I don't know why she says that. I don't think there's really a good basis for it. I think she's wrong. And I think that if you need testosterone, it's a game changer when you add it to your hormone replacement. Not everybody needs testosterone. Some women go into menopause and still maintain really healthy levels of testosterone. So testosterone, you have to measure. You don't just give someone testosterone like you might feel free to do so. If a woman comes in and she's going to get her blood level or whatever way you assess hormones done, you might feel if she has insomnia, you can just go ahead and give her a script for progesterone, and right after she gets her blood drawn, start the progesterone because it's rather safe. But you wouldn't do that with testosterone. You'd get a baseline study of testosterone because she could be high or she could be low. Here's a study. Emerging observational evidence suggests that the higher levels of testosterone, this might be one of the studies that she was pulling this from, after menopause may increase women's risk of cardiovascular disease. So they wanted to take a look at this. And this data came from something called the multi-ethnic study of atherosclerosis, which appears to firm up this potential association and to underscore the importance of accurate and reliable testosterone measurements in women to understand their role. So what they did, it's an ongoing study of 6,000 men and women from across the United States, and maybe this is the study that Pam based this on, indicating that postmenopausal women with higher blood, but I'm going to tell you the caveat, with higher blood levels of testosterone to estrogen, I opened up saying it's the ratio, have a greater risk of developing coronary heart disease and heart failure, according to the study's senior associate director of preventive cardiology at Johns Hopkins. She noted that higher testosterone and higher estrogen were linked to greater and lower heart disease risks, but that higher testosterone to low ratio seemed to be the best indicator of all. So what the literature suggests is women with elevated testosterone and not enough estrogen, that it's a balance between the two. So if estradiol is low, estrone is low, estriol is low, but testosterone is high normal, that's when testosterone might be more a driver pro-atherosclerotic than a protector of plaque in blood vessels. I think that's the deal. The ratio is the deal. So this multi-ethnic study of atherosclerosis showed that women with the highest T with the lowest D had the worst coronary vascular disease outcomes. So I think Pam is misinterpreting the literature. It isn't just elevated T causes plaque, because we see how much testosterone protects arteries, protects inflammatory markers, protects lipoprotein little a. It's the bigger picture if you have elevated testosterone to insufficient estrogen. In real life, a woman needs testosterone, but you just have to make sure that she's also on estrogen and that she doesn't have more estrone than estradiol. That's something I'm always looking at in the blood. I don't want the estrone, which is more of the, estrone is more the growth hormone. Estrogen, 80% of it signals ER alpha than the other receptors. But once in a while, if I have a very, very, very thin woman who's not doing well, I'll put her on Triest. It's not like I always only use Biest. Some women who are very, very thin and have no estrone might need a little estrone. So you always have to individualize. So it says here, you know, the whole idea of the reference ranges is bogus, because most women feel a little bit better, a little bit higher than the reference ranges. And can you relate the common highs and lows of sex hormone binding globulin? Well, sex hormone binding globulin is a carrier protein, and when it's elevated way above the higher number of the reference range, and reference range is on sex hormone binding globulin vary a little bit with the labs that you use, it binds up testosterone. So I really go on how a woman feels with testosterone, but I usually like to see the high level of the reference range or a little tiny bit over the reference range with testosterone. So for women, they might feel better with a free testosterone that's at 4, 5, 6, 7. Some women feel better when it's an 8 or 9. But if it's really in the low level of, remember, reference ranges on blood labs and are based on unhealthy many women. They're not ideal ranges. So I don't really go too much by them, but just FYI. I'm a retired nurse and certified in applied functional medicine. I'm not a prescriber, but I do suggest DHEA and estriol and progesterone and then retest. You know, DHEA really doesn't give you testosterone in older women. It just doesn't fulfill the mark. It's a really wimpy way to try and get androgens, but it's better to be on some DHEA than not on anything. But DHEA is not really going to give us, especially as you get into your 60s and 70s, enough testosterone. I've also taken patients, what is that, HPT?
The glandulars.
Oh, glandulars. Okay. And many will recommend pregnenolone to increase DHEA inconsistent. You know, pregnenolone, once you get into your 60s and 70s, these gyrations of giving DHEA and pregnenolone don't work to up testosterone in older women. Just doesn't work. You can use it when people are really younger, but have you seen it work?
Yeah, I'm 64 and I take it.
And it's got your testosterone in your normal ranges?
Yeah, I haven't tested
without taking testosterone.
No, I've never done the bioidentical hormones.
So what is your testosterone level?
I have to look at my last Dutch, but I tell you, I really notice a difference in my muscle mass.
Okay.
Or without it. So,
well, never say never. Well, that's really good to hear. It's always good to hear. Most of my women that come in on DHEA does not help their muscle mass. I've just not seen that. But you know, you're only 64. You really, really start seeing problems with hormones from 65 onward. When you're first in menopause, your 50s, you still have a lot of your life force left from your younger years. And then even in the first few years of your 60s, depending on how you're living, and if you're living really well, you can go up to your mid 60s where you still have a lot of robustness. And then aging really hits speed in the second part of your 60s and as you enter your 7th decade. So it'll be really interesting to see if for you, DHEA maintains your muscle mass as you get into the second half of your 60s. But how come you're on DHEA and not testosterone?
Just not trusting the medical community, not having a provider near me or that I know.
Gotcha.
Not wanting to do pellets. Just studying this myself, saying, and I was on the Depo-Provera shot until I was like 42, crazy as that sounds, before I was educated, and went into menopause then. So
at 42?
Right. And didn't take any hormones until maybe 3 or 4 years ago. So when I started.
Why was that?
I was just uneducated, just wasn't enlightened.
Okay, so it's so good that you're on hormones now, because you know that really famous study from the Mayo Clinic where women that go into menopause 45 years and younger and don't go on estrogen have like an 85% increased risk of a first-time fatal heart attack. It's a huge study that they tracked women, and that study proclaimed if you go into early menopause, you need to be on estrogen to protect yourself against a fatal heart attack. So it's really good that you're on hormones now, because you really went through menopause at that earlier, more vulnerable age.
And totally induced by
what?
By what did I just say? The shot, the
Depo-Provera.
Depo-Provera.
When I was young, I had a lot of excessive flooding and hemorrhaging, and they didn't know what to do with me. Of course, it meant I needed more progesterone. I was DS daughter, and I was so estrogenized, but no one knew this, right? Nobody knows any of this. So they gave me a lot of those Depo-Provera shots to try and then what that does is it's very hard on your bone mass. So, Depo-Provera is one of the reasons that we have an increased incidence of osteoporosis as an epidemic. It's really harsh on osteoblastic activity in bone. But well, good for you, you know, so you're able with DHEA to maintain your testosterone levels, and you feel, what is your total testosterone? Do you know?
I'm trying to look at my last tests. I can't pull them up
Okay.
right. I'll look it up
And then, well, let me just keep going here while you're doing that.
yeah.
This was in the British Journal of General Practice, and it said, should we be prescribing testosterone to perimenopausal and menopausal women? And it's a guide to prescribing testosterone for women in primary care. And now there's a number of med schools in the United States that have taken these guidelines because, you know, to use testosterone or not to use testosterone is very debatable in women. Now we've got Pam training a whole group of women that don't. So this was very, very interesting to me that they just hit this head on. They said testosterone is one of the sex hormones that women produce, yet it's often overlooked. Women actually produce 3 times as much testosterone as estrogen before menopause. Levels of testosterone gradually decline in everybody as they age, or they reduce abruptly following oophorectomy when you get your ovaries removed. The most commonly described symptoms of the androgen insufficiency in women is dysphoric mood, because testosterone has a great effect on your brain. Unexplained fatigue, change in sexual function, including reduced libido, changes in cognition, hot flashes, bone loss, and decreased muscle strength. These are all things that androgens help support. Reduced or lack of libido is very common in menopausal women, and they say that when you do give testosterone replacement, it can extend and include a woman's sexual life, but it has a lot to do with her level of energy. And energy is real money in the bank, and a lot of women really don't get the bang of their buck of energy until their testosterone levels come up. Now, you're getting it probably with your DHEA. I just don't find that most of my ladies, and I also have some ladies, DHEA rules the sebaceousness of your skin. Some women can't take more than a few milligrams of DHEA because it gives them cystic acne no matter what they do. I have to be on only 1 milligram and get it compounded, otherwise I get cystic acne. So there's a lot of caveats with DHEA, and you have no idea which way it's going. It's a parent compound. So it's not an ideal way to sustain testosterone. It's not. But if it's working for you, that's fabulous. So never say something is never, because if it works for you and you don't have to worry about what you have to do to get testosterone, because testosterone now is a controlled substance. You have to see a physician twice in person a year if you're on testosterone, and you have to get a CBC every time you go in to make sure that you're not getting thicker, more hypercoagulable blood. So testosterone is much higher maintenance hormone. If you're seeing somebody and you're on estrogen, you can see them once a year. But if a doctor prescribes testosterone for you, you've got to go in twice a year. And that's the law. Otherwise, the doctor can be severely fined. But they said here as a conclusion, and this came out in 2020, testosterone could be important for women for bone density, muscle mass, cognitive function, mood, sexual function, and adequate levels of testosterone are important for the maintenance of musculoskeletal and possibly vascular. So this whole idea, let me go on to the next thing here. Evidence to support testosterone use in women. This is that British study. And they say basically in this study, testosterone is the forgotten hormone in most women. And a recent systemic review and meta-analysis of testosterone treatment of women have provided robust support for a trial of testosterone in women because they seem to do so much better all the way around. It's important to ensure women are adequately estrogenized, though, before adding testosterone. This is the caveat. This is usually the case when they are no longer experiencing hot flashes or vaginal dryness. So they basically say over and over again, the real issue of testosterone to warn about is you don't want to give testosterone without also making sure that the estrogen levels are coming up. And that was what I saw might be what's really the issue with testosterone, not that it causes plaque. Make sure you have adequate estrogen and make sure that the vaginal vault is lubricated. When you're on enough estrogen, your vaginal vault is lubricated. If it's not lubricated, you're not on enough, or for some reason that woman needs to have application into the vaginal vault, and you want to make sure that they don't have hot flashes at night. Let's see. There was also a global census. This is a global consensus position statement on the use of testosterone therapy in women. It was published in Climacteric in 2019. And these are all the people that put this global statement together out of the United States and around the world. This is a global consensus position statement on the use of testosterone therapy for women. It says testosterone appears to be safe when used transdermally and low doses. Their big issue is pellets, and when you get super physiologic levels. There are little long-term safety data on the use of testosterone in menopausal women beyond 2 years, except Kenna Stephenson had it for 3 years. And she had very intricate monitoring of all the vascular and cardiovascular, like the metallomatrix and arterial stiffness. What is available and is reassuring is that transdermal testosterone is not associated with an increase in blood pressure and has no adverse effects on lipid profiles. So Linda Lee, I don't care if Pam is an MD and I'm not an MD. I'm tired of all that old stuff. I am so done with that, because it's all about what you know about the science and how much you know the details of this space. And the majority of medical docs don't know the details of this space. It's become so apparent to me. I don't mean to become a shrill, angry, reactive older woman, but it's hard not to, because I'm no longer intimidated about not being an MD or that an MD makes that statement. I am done with that. Let's look and see what the science says. So this is a global statement. This came from all of these places, including the Endocrine Society of Bethesda, Maryland. I mean, this is the North American Menopause Society out of Cleveland is one of our most conservative societies that guide gynecologists on how to proceed. So they all put this global consensus statement together, and they said testosterone is not associated with any adverse effects on lipids as long as it's not in a supraphysiologic range for a long period of time. So they worry about pellets. That's what they basically worry about. This position statement has been endorsed by all these people, and they say that there's no clearly established indicator for testosterone. Nonetheless, clinicians have treated women with testosterone for decades with the intention of alleviating a variety of symptoms. In most countries, testosterone therapy is prescribed off-label, such as women are using it in a variety of formulations that are usually meant for men, because most of the research was based on men. But because of these issues, there's a compelling case and a need for a consensus statement, which is why they put all this together based on the available evidence from placebo comparative randomized trials. So that's what this consensus statement is. And the recommendations regarding the conclusion of this global systemic statement is recommendations regarding systemic testosterone therapy for women in doses that approximate physiologic testosterone based on findings from multiple, is that it does not cause any problems with the blood vessels unless it is in excessive physiologic ranges. They say we don't like oral testosterone therapy. That's the studies that show adverse effects on lipids. Transdermal testosterone does not show adverse effects on lipids. And I wonder if also there's several caveats here. Oral testosterone, not good. Topical testosterone, good. Testosterone with low estrogen, not good. Testosterone with adequate estrogen, good. There's caveats of the testosterone in the literature, but overall long-term use of testosterone, and the longest study that's looked at it so far is 3 years, only shows improvement in all cardiovascular parameters, not worsening. Studies of non-oral testosterone, which is basically topical or injectable, in doses that approximate physiologic testosterone, have shown no significant adverse effects on lipid profiles over the short term. And that's because there are no studies on it at the moment longer than 3 years. Testosterone therapy has not been associated with increases in blood pressure, hemoglobin A1C. This is the global statement from the most conservative gynecological societies from all over the world. So I don't care that Pam has an MD and is saying that, and I really like Pam a lot. We lecture together all the time. Testosterone therapy does not increase mammographic breast density. Available data suggests that short-term transdermal testosterone therapy does not impact breast cancer. Testosterone protects bones. We know that women that fracture bones have a darker potential outlook and a higher mortality rate. And testosterone is very bone protective. This Miami says among young to middle-aged women with no heart disease, increasing estradiol and sex hormone binding globulin had association with less plaque, but they did find higher free testosterone was associated with a little bit more plaque. So this is the study out of Miami looking at 2,300 women who didn't have any heart disease and just looking at their level of hormones. Maybe this is one of the studies that Pam is looking at. They're saying women with really high free testosterone had a little higher risk of plaque. But if they dove deeper into that study, when the sex hormones were explored as continuous variables, we found no association of total testosterone, free testosterone, and DHEA with plaque. So if you read the abstract, it looks like higher free testosterone gives you more plaque. But if you read the bowels of the study, that doesn't say it. So sometimes the abstract doesn't reflect what's going on in the bowels of the study. So when they dug deeper, there was no issue with testosterone and heart disease. Then there were some questions about how to treat young men, but we're at 11:11. So I think I'm going to go through that at another time. And I want to go to the questions. So I'm going to pop out of this here and stop my screen share. And then go to the questions over here. Where's my questions? Chat. Why am I not seeing my questions? Here it is. It's over here, chat. So, see. So go up here. Is there a clear science that says HRT is beneficial? Yes. There's more that says it's helpful than not. Why does Dr. Smith speak about the detriment? I don't know. Hard to counter. So that's why I gave this whole talk. And we've talked about that. Your outrage is, I've really worried recently that I'm sounding like a shrill, angry old woman, and I don't mean to, but I hate that my sisters of the heart are missing out on what I have to be so strong. It makes me upset. I'm trying to calm myself down because I don't think it's good for me to be shrill, but your outrage, thanks, is founded. Please keep, whoops. And proud, okay. Velvet deer, antler, horny goatweed, how do the herbs compare? There's definitely some herbs that can raise testosterone. I know Vital B from Biotics has a study in men where it elevates testosterone, and it basically is using herbs. And it was a controlled scientific study. And I've also used Vital B in some women that couldn't have access to a doctor to get testosterone to raise it up a bit. But as you get older and older, the herbal building blocks for testosterone work a little bit less and less. So that is something that you'd have to try with a patient, but honestly, most women just feel better with a little tiny bit of testosterone. It might even need to be like 1/10 of a milligram or 2/10 of a milligram. Usually the dose range of testosterone is somewhere between a few tenths of a milligram to 3 milligrams. But I deal with a lot of patients from LA where they have to be very thin on camera. And I've noticed in LA that the doctors there are giving 5 to 10 milligrams of testosterone to women, and their voices are real low and they're building a lot more lean muscle mass. And that to me is a super physiologic dose, but they're doing it because the whole emphasis of that town is on thinner, 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 because the camera puts 15 extra pounds on you. So you have to be extremely thin to look a normal weight on camera. So that happens to be one area of the country where a lot of the prescribers go much higher in their testosterone. But interestingly enough, have we seen when we monitor the calcium scores in these women, or the ultrasounds of the carotid, any worsening? No, not yet. I haven't seen that to be the case. So just FYI. My Dutch test shows an increase in testosterone with your DHEA. Well, that's great. So how much DHEA are you taking?
Sometimes I'll take an extra. Yeah, I'm doing the suppositories, and I think it's only like 3 to 5, or there's
Milligrams?
6 milligram one. So I do a combination of estriol. I think it's 1 milligram of estriol, 20 of progesterone, and 3 to 5 of DHEA. And then occasionally I'll take an extra DHEA in the morning.
So where do you get the suppositories?
Beswecken.
Oh, the Bezwecken suppositories. Gotcha.
Oh, but I have to tell you what
I
really
love Bezwecken. It's a great company. Great
what
company.
really turned my life around and
Yeah.
my relationship with my husband was your book, Sexy Brain. and got my husband to get on testosterone. And then our sex life has improved better than my wildest dreams. So, I'm getting testosterone from my husband too, I think. So thank you, Lindsay Berkson.
I've had 3 people send me pictures of themselves with their mates saying that book got them back together again. One couple, she sent me a picture of her reading to her husband. They were going to get divorced. They were separated. They'd been married 10 years. And she heard about my book, but she really missed being with him, but they had issues in the boudoir. So she suggested to him, before we get a full-on divorce, why don't we go on a road trip and I'm going to read you Sexy Brain. And she sent me a picture of reading, and I've got it. I actually should post it sometime on a Substack. So she took a picture reading the book to her husband while he was driving, and they got remarried, and they had a second wedding, and now they've been together another 10 years. And she said a very similar thing. So that's kind of cool. And here I am, single. I'm helping everybody else with their libido and their mates, and I'm still out there looking for mine. It's an interesting fickle finger of karma in this world. So what testosterone levels trigger a red flag for you when you are supplementing transdermal? First of all, women can have really high testosterone levels and feel good. I don't get alarmed by testosterone levels that are high. The only thing is one of our members had a patient that she does pellets. So her testosterone levels were 5 to 8-fold elevated. But the patient felt great. The patient was a lawyer. The patient went on to get breast cancer. The patient sued our member for over $1 million. And I was in communication with her almost on a daily basis. It was a week jury trial. And the jury did not want to have the lawyer win. They actually were on the side of the gynecologist, but they ended up where they won because the patient was maintained in blood levels that were really super physiologic. In essence, that patient actually probably had breast cancer. It takes 10 years to form a tumor on the average. So she'd only been on hormones about 2 years. It's highly unlikely the hormones had anything to do with initiating the cancer, and much more likely that she was much better off and had a much better chance of not dying and having a less aggressive disease because she was on hormones. We're learning that hormones, if you get breast cancer, put you in a better position. But that's not known. That's in the science, but it wasn't, the lawyer wasn't able to communicate that to the jury. But the jury the doctor lost because of the supraphysiologic levels, but the jury only awarded that lawyer $100,000, $90,000 to $100,000, much different than the $1 million plus that she was being sued for. But it's not so much the supraphysiologic levels that I worry about. It's really that if something happened to the patient, you're in a much more legally vulnerable area if the blood levels look like they're 5 times higher than what they should be. But a lot of women feel better when testosterone levels are higher than the normal range. You usually know if somebody's elevated by they start getting angry. I was starting to look at my own testosterone levels. Maybe I'm getting angry from all the hormone stuff because my testosterone's a little bit too high. So I was starting to try and tease that apart a little bit, because I'm have so many organs that I'm missing. I tend to go to 3 milligrams of testosterone a day, because I have only one adrenal gland and no ovaries and etc. So I tend to be on the higher range of what I would do. Most women are at 1.5 milligrams to 2 milligrams of testosterone a day. I have one woman right now that I've been working with for a few years. She's on 5. She's the highest dose testosterone patient I have. She's 5 milligrams. And at 5 milligrams, her libido is on mark. She loves making love. Her life is different. And when she goes to less than that, she's not. So that's the range that I look at, is a few tenths of a milligram to potentially up to 5, but the average dose is 1.5 to 2 milligrams of testosterone a day. Does that work? Is that helpful?
Yep. And then on the lab, so if you're seeing 60, 70, 80, you're fine with that. 100, you're fine, as long as
I'm fine with that. But the only thing, if it's, you just got to be extremely careful. If you were in a lawsuit and you are really well above reference ranges, you're more vulnerable. So you have to look at how the woman feels, and you have to really look at her history, and you have to make that decision on your own. A lot of women don't have peace of mind unless they're within the reference range of the lab. They can't get that out of their brain. They go, I'm high, I'm high, I'm high. So sometimes you have to just lower the level of testosterone to bring it within the reference range so the woman has more peace of mind, because people get so Velcro to those lab numbers. And the lab numbers really aren't the end all be all, but they are in the American culture. So sometimes the woman will come in and go, my testosterone's high, my testosterone's high. And she's so worrying about it that you got to lower it just to bring her some peace of mind.
And then did you see the prior question there? I did have one adverse reaction to pregnenolone 25 milligram, just once a day. She had stress response insomnia, and it killed her appetite. So what is that scream anything to you about that particular patient?
Well, first of all, that's unusual to get that reaction, but that is the problem with things like pregnenolone and DHEA. They're parent hormones, and you don't really know what they're going to go to. And so pregnenolone does go to progesterone, and progesterone is your most allergic hormone. If you go to PubMed and put in progesterone and allergy, there's 65 articles on progesterone, autoimmune progesterone-induced dermatitis. It is the most reactive hormone. So if a woman has an issue with progesterone and you give pregnenolone, it could be creating progesterone that she can't handle. It's hard to know, but pregnenolone does go down that pathway, and
also down the cortisol path.
Well, so it can go anywhere. You know, it's a parent hormone. The only thing is you don't know if she had that reaction to just that company's pregnenolone. Maybe it's not really pregnenolone. Maybe it was something the way that company made that product of pregnenolone. So the first thing I would do, if you felt like she needed pregnenolone, because we think of it as the memory hormone. So if nothing else is working with memory, and pregnenolone is something that you might use. I mean, I don't even use pregnenolone that often or always test it. But if the first thing I would do is try her on a company and make sure it wasn't just a reaction to that one specific company's pregnenolone.
Yeah. Okay.
You know, I don't know. It's an odd response, and it's a very low dose of pregnenolone. One woman, I had a very interesting email one time with a woman that wrote me on Facebook. And she said, I've been following your work for a while now, and I've always been frightened of hormones. And I live in a really small town, and there's nobody here that does hormones. So finally, all that I did is I just went on pregnenolone. And she said, I went on 90 milligrams of pregnenolone, and it changed my life. I feel like a better person. And she just did this litany of all these improvements just from going on pregnenolone. And she was so improved, she felt inspired to write me on Facebook and put this out there. So sometimes a parent hormone can be extraordinarily great. And sometimes I've never had anyone have that reaction. You can have an adverse reaction. If you have an adverse reaction, the first thing you think of is it this company's product? Would she have that adverse reaction with a different one? And is it because it was promoting downstream hormone production? The first one you think of is progesterone, which is the most alert. You could be reactive to any hormone, but progesterone is the most reactive. We know this because it has 65 peer-reviewed citations of it inducing immune progesterone-induced dermatitis. So you could go look this up on PubMed. So why is progesterone such a reactive hormone when it's a hormone that progest supports life? It's a major pregnancy hormone, and it's made 5 parts in the brain in young patients. You have progesterone producing enzymes all over your body. We think of progesterone is mainly produced in the corpus luteum and the luteal phase, but it's actually produced in the valves in your coronary arteries to help protect the valves because it's so anti-inflammatory. We can use large doses of progesterone to reduce neuroinflammation, and it's even being given like a 200 and 300 milligrams to kids who are 8, 9, 10 years old that have severe ADHD and processing issues, because progesterone is so brain protective. But it's got this other caveat that it can also be, for some reason, reactive. And we don't totally understand all of this about progesterone. All we know is it's one of those things. So I would want to figure out with this patient, first of all, would another product cause that issue? And if it did, does she have that issue with progesterone? Have you put her on progesterone?
Yeah, it was biotics. And so I think that the quality of the product is fine. I could have her go back and microdose small amounts of it, see what happens. And she's already on bioidentical hormone replacement
So
therapy.
she's on progesterone and it didn't bother her.
Yeah. So she might just have like magnesium deficiency. Like if you upregulate catecholamine production, like if you're making too much cortisol from the pregnenolone, she probably just needs magnesium to clear it better. And really, and in that scenario, it would have given her more energy, something like that. So,
well, will you keep us in the loop? Because that's really interesting. I have never had a patient have that response to pregnenolone. And let's see what happens when you do give her more magnesium. That's an interesting thought that you had. So could you keep us in the loop?
I sure will.
That's the one thing with hormones is you start using them and you have this template of what might be helpful, but you just never know how the patient's going to respond. Yeah. And then so I would love to go over a lot more cases. So if you guys could just bring cases in, we could talk about them and kind of process this, because what we're learning is didactic, but it then really shines and is graspable when you put it in a case. So let's have people send in cases and let's go over them and let's talk about them.
I do have one interesting one I can just mention, and she's actually not my patient. She's a friend of mine at the gym. She's she's premenopausal. When the bioidentical hormone clinician, I think it was a certified family nurse practitioner, when she checked all of her hormones, found that the only thing she was low in was testosterone. She chose to do the pellet at the lowest beginner dose, and it like solved all her problems. She lost 10, 15 pounds. Her anxiety went away. Insomnia improved, so it kind of fixed all of her parameters. And then in that month 3 mark, when their levels start to taper and then you need a new pellet, all her symptoms came back. So and I think the other thing she was prescribed actually was DHEA. So that
she would have been interesting if you could have just given her DHEA and saw that she so clearly responded to the testosterone therapy. Would have been really interesting in her for the next series, just to give her DHEA and see if she got the same improvement.
Yeah, right. So
is she just continuing with pellets? Is that what she's doing?
She loves them. She loves them. Yeah. And I think she's like 42, so she's younger,
The best time to start hormones is when you're younger. You get the most brain protection in your 80s. You get your most long-term protection with earlier initiation. But then people constantly say, well, I have an 84-year-old. Can I start her on hormones, or has she missed her window? I don't think you've ever missed your window. You just have to go really, really slow because the receptors have been senescent. And when they wake up for 1 year, they're hyperactive a little bit. So you have to go much slower, and you have to make sure that you also have some, because most older people have some heart disease. So I like to always put older people on hormone replacement for a few months, for a month first on my products, along with our Tiracell and Vasconox, because our Tiracell, as we learned from Dr. Messer, makes the blood vessels like nonstick cookware, and Vasconox expands them. So if you just I like to do a 1 month of cardioprotective prepping before I then initiate the hormone replacement in the older patient. And then this will be the last question. If a 55-year-old male total T level is 580 and excellent libido, Would you supplement him for other potential benefits? If libido and erectile, no, if somebody's at 580 and they're feeling great, I wouldn't even touch it. I'd just leave it. I'd leave it. If you don't need hormones, you don't need hormones. Unless, let's say that patient had autoimmune disease. Or let's say that patient had SIBO and leaky gut. What we've now learned is testosterone upregulates secretory IgA. It helps prevent bacterial translocation. It's a gut protector. So, I'd look at the bigger picture. But if there weren't any of the other things, I would just say, you do really well at 580. Let's just leave you. Let's not even look at it until you're not. So that's what, and I think that's the last question. Yeah. So what do you, I don't know why Pam Smith is saying avoid testosterone. This was my dive into looking at testosterone, and all I could see was topical testosterone, because they don't like super physiologic doses with pellets. And a lot of women love pellets. I'm not anti-pellets at all. Topical for at least 3 years only benefits the heart. But what you really want to make sure is they're also on estrogen, because it appears that higher testosterone with insufficient estrogen, that's a ratio that's not good for the heart. But I could not find any validation of what she's saying. Even look at that global consensus statement from the most conservative global menopausal societies. So I really don't understand it.
I wonder if she would share with you personally if she had a like any litigious thing from, but she's still in practice, right? She's treating patients. I wonder if she had a bad experience with somebody. She's kind of veering toward the safer or less hormone promoting side of things. But
I don't know, but we all tend to see the world through our own glasses and lenses. And Pam always, when she gets up there, she always says, I hate exercising. Everyone who knows me knows I hate exercising. Not that you have to exercise. The blue zone people don't really formally exercise. They just have a lot more movement within the context of their life. But Pam's muscle mass is a lot less than my muscle mass. And I'm almost 10 years older than her. So, but this is what's being taught at A4M, which is why I put this together, and I couldn't validate that fear. If you find anything else, let me know. And I think where are we with everybody here? We still have, hi, Chris, we haven't seen you in a while. Christine, Roche, welcome back again. We haven't seen you in a while. Let's see you. Can we see you? She's not to be seen yet. Okay, well, I'm going to write Pam a letter because she wrote me. I heard from my rebuttal for Mercola. Felice Gersh reached out to me and said, thank you for doing this for women. We need to do something to make women not be so fearful of estrogen. And last night I got a text from Pam Smith, and she said, thank you for doing this for women. I really appreciate it. So I am going to reach out to Pam and say, hey, I did a deep dive on testosterone and plaque, and I can't really see it. Can you please send me your citations? I can't seem to find them in your book. So that's what I'm going to do, is ask her that, and I'll let you know what she says. But a lot of what Pam says and teaches is really good. So this is something we'd like to have clarified. But am I going to go off my testosterone? No. I'm not going to do it. So I think we're done. Any other questions? So we have several homework here. You're going to let us know about that patient, what happens with the pregnenolone patient. And then what else are we going to do? There was somebody else that was going to do something. What was our homework here? I can't think of what it was.
Everybody needs to bring a case study next time. How's that?
That's the homework. Everybody next time, but you got to send it in to me the week ahead of time. Send it in to Sarah so I can take a look at it and put it up on the slides so that we can then all see it together. So please everybody send in one case report, and then let's start going over those and making this real time.
Awesome.
Oh boy, so this whole thing against hormones in the United States, at the same time that birth control pills are now available over the counter, none of this makes any sense. This doesn't make any sense. Because What a beautiful country, but greed has overtaken our country. Greed has overtaken our country. So thank you for being greedy list people whom I adore. And I look forward to the next time. And if you have any questions, please send them in. The other thing I want to cover is somebody had sent in questions. What do you do if somebody is a young guy and he's been had low testosterone and was given testosterone shots and now is infertile? How do you use HCG? Are you interested in knowing exactly how to use HCG in young guys? So I have a bunch of slides that we'll go over with that. And this is all based out of the Department of Urology from the University of Florida. They gave us very specific guidelines for all of this. So I went into all of their literature and studies and I pulled it from there because this is not something that I have a lot of experience with. This is not, that's out of my bailiwick. So I'm going to share what the Department of Urology from the University of Florida says about the use of HCG and rebooting fertility, rebooting sperm production in essence, and how to treat young men that have low testosterone safely. Okay, everybody. Case reports. Blessings.